a very welcome to Miami to this 26th ISMICS meeting. It's my great pleasure to welcome you, and I think we will have a great program. The program chairs have worked very hard, and we have now 375 physicians registered and 200 and something with industry. So it's a good attendance. And maybe there will be more. And we will thank the exhibitors because they will really contributed very much to this meeting, all-time high. So please go and visit them. They are very interesting. And now I think I just start the session. So I will ask the moderators to come to the podium. And I will also tell you that we have kind of merged the two first sessions so that there can be some overlap and changes. So please stay in the room and be updated. So now I will ask Dr. Kempfert and Dr. Patel to come to the podium for moderating. And also I will ask the panelists to come. Aren't anybody coming, or are you? So, and then I will also say to the thoracic guys that your program is one level down. So if you want to be in the thoracic program, you have to go to another room. So a very warm welcome and enjoy the meeting. And I now give the word to the moderators, Dr. Kempfert and Dr. Patel. And we have also panelists, Dr. Nguyen, Dr. Imchoy, and me. So.
Thanks, Green. So welcome to the first sessions. So as the first session will integrate live surgery, this makes things always a little bit more challenging, but of course the surgery comes first, and this is why we need to organize the program a little bit around the surgery. So Nirav, of course we want to kind of sync with the OR, and there's also a time zone different. It's only 1 hour, but it's early in the morning, so to adapt to everybody so that there's no delay in patient care, we have reorganized the program a little bit, and to not get you guys confused, Nirav is going to update you what's going to happen, correct?
Yes, so because our live surgery is from Tennessee, and we have a time difference, and we don't want to disrupt the patient care or the routine of patients, so that patients come first. So what we will do is we will go live, hopefully around 9:45 our time, for the mitral case by Dr. Ovilio Rodriguez. So we'll do the first 3 talks. We will jump into the abstract session. And then when Dr. Rodriguez is ready to go and cross-clamp, we will go live to Tennessee. So we'll play it around. So bear with us for the last minute change in plans, but this is what we have to do. So we'll kick off with the first talk by Dr. Bonatti, who needs no introduction, robotic heart surgery, how it all began.
Okay, thank you very much. Let us reflect on how the robotic component of less invasive heart surgery began. I will concentrate my talk on the development of the TCAP procedure, which was my main focus during my robotic career. These are my disclosures. As most of you will know, the world's first ever robotic procedure was a totally endoscopic coronary artery bypass grafting procedure. Oh, here is the, okay, done by Didier Lulmay and Professor Carpentier in Paris in 1998. They published their case in 1999 in JTCVS. This case was done with cardioplegia and the aortic endoballoon. Didier provided me kindly with a video, short video of this procedure. You see here, everything was a little primitive. It was a prototype that they worked with. Some functions had to be done with a laptop, but they were able to perform a completely endoscopic coronary bypass grafting procedure, Lima to LAD. Volkmar Falk, at that time in Leipzig, went to the Intuitive Labs in Sunnyvale with the task to develop the beating heart version of this procedure. You see here a scheme out of his publication in the Annals in 2000. They worked with a dual console system, very interesting, and had a prototype of a endostabilizer at hand. Volkmar and his team did a lot of simulation, and I really want to point this out. This was only successful due to the many repetitions on simulators that they did. We see on the right side here the anastomosis on the cadaver pig hearts that they did, and they checked on the patency of those and also did some animal experiments before they went back to Leipzig and did the first beating heart TCAP there. Volkmar, together with Professor Moore and Stefan Jacobs, did that procedure. Big merits also by the Dresden team, by Homo Alzichon and Utz Kappert, who also helped develop the beating heart version of the TCAP procedure. We see down here a prototype of the stabilizer that they use, which are also allowed to put the elastic tapes into these buttons on the stabilizer. Volkmar Falk kindly gave me these pictures of other prototypes of the robotic endostabilizer, the EndoWrist stabilizer, that were used until it came on the market. I really would like to point out Doug Boyd from London, Ontario, who in 1999 was successful in using the Zeus system for a beating heart TCAP procedure. Very remarkable, as this system, as many of you will know, didn't even have wristed instruments. So big achievement, and I think Bob Kia is here, assisted that procedure as far as I have learned here, the intra-op arrangement, and they had this endostabilizer available for that operation. A first multi-center study came out in 2007 by groups from Europe, and the picture here shows Didier de Canière, a surgeon, very skilled surgeon from Brussels, who led this project here. They reported on 200 cases, half of them beating heart, half of them arrested heart, with very good results as compared to the results at that time in the STS database. We were all in the early phase tortured by high conversion rates. You see here that for the arrested heart version, we started out with 30% conversion, beating heart, 70% conversion to larger incisions, but all that came down in that publication within 48 months, so 4 years, to less than 30% in beating heart and less than 5% in arrested heart procedures. But we learned, and the community learned. I had the privilege to start robotic TCAP in 2001. My former boss, Professor Laufer, who was recruited from Vienna, got a first-generation Da Vinci device with his recruitment, and he put me in charge. You do that. That was my gateway into a beautiful robotic career. This shows me behind a prototype also of the Da Vinci system in Utrecht at the lab there, where I learned this procedure. That was in 2001. We did one cadaver model, we did one porcine model with IMA harvesting, and several Lima to LID anastomosis in cadaver pig hearts. I want to thank our long-term respected member Paul Gründemann for helping me through that phase. We went back to Innsbruck in Austria and started with robotic midcaps, and then in fall of the same year did our first TCAP operation. The first generation system, which you see here, had only 3 arms. the ports were shorter, the instrument shorter. Sometimes we had to push in the ports to reach the distal end of the IMA. We had optical lenses instead of HD that we have today, and fewer functions were controlled from the console. You see here our past president, Nikos Bonaros, who was working in most of the cases with me in Innsbruck. And I would like to especially thank Dr. Gerhard Wimmer-Greinecker at that time at Goethe University in Frankfurt, who proctored me in the first cases. Gerhard Wimmer-Greinecker was also instrumental in developing the totally endoscopic ASD repair, which you see on the right side here, a completely endoscopic version done in the early 2000s, a procedure that really deserves the term totally endoscopic. The Da Vinci system received FDA clearance for coronary bypass surgery in 2004, and I had the privilege again to participate in the FDA trial, which was led by Mike Argenziano from Columbia University. You see here Mike in a famous US show reporting on robotic cardiac surgery. To show you how the procedure looked in these 85 cases that were part of the study, it was a 6-hour procedure. IMA harvesting took a little more than 1 hour. Cannulation, these procedures were done with the endoballoon, took a little less than 1 hour, a little more than an hour bypass time, and a little more than 1 hour of cross-clamp time. What you see here is that the procedure elements of dissecting the LAD and the arteriotomy are not so easy and were the harder parts, and took some significant time, and the anastomosis a little more than half hour. We dealt with a conversion rate of 6%, much better than in the very early phase that you saw. No mortality, whereas in the same time, the single vessel Lima LAT mortality in the STS database was 2.5%. We had no stroke and no aortic dissection, important as these cases were done with peripheral cannulation and the endoballoon. I would really like to highlight the work of Sudhir Srivastava, who at that time at Odessa Hospital in Texas did a large series of TCAP procedures with great results. And he used the so-called U-clips, which you see here, titanium clips on titanium needles, which helped him bring down the anastomotic time to a very short one. These clips were unfortunately taken off the market at some point. Also to point out, Bob Kiai's work, he was the first to do a TCAP procedure in Canada, in London, Ontario. He kindly gave me this newspaper article, and Bob was also the first to do a simultaneous hybrid intervention combining robotic midcap and PCI in the same session. During that phase, everyone almost went into hybrid already, and Bob did this in the same session in a hybrid operating room. Here you see the 32 surgeons who at the mid-2000s had ever done a robotic TCAP procedure. We see several of them even here. They all need to be respected and thanked for their pioneer work. Some of them left the field, but 5 of them, if I counted correctly, became ISMICS presidents. What helped us was the introduction of the next generation of Da Vinci systems, the S and SI systems. They had longer instruments, better optics, 4 arms, TilePro to display the hemodynamics during the procedure. Very important guided tool change, that the instrument would go into the same exact position as you had before. Beautiful safety measure, and the robotic endostabilizer, an instrument which you see here and which we all hope comes back soon to do proper beating heart TCAPs. Thank you very much.
Thank you. Any questions from the audience?
Manny Subramanian. Just a comment. Johannes, thank you very much. And I think we should really pay respect to Dr. Elaine Carpentier, who did the first ASD with the pseudoaneurysm in early May, and also Fred Moore, who did the 5 cases of attempted TCAP, but the ethics committee wanted to have a mandatory mid-cap incision. In the 2 of them, he had a difficulty in Lima, but the rest of the 3 completed with the cardioplegic arrest, and through the ports, he did the anastomosis. And because of the difficulty, he came back to Paris, and Didier did 8 cadavers and training, and 4 he did, actually. 2 of them he had to convert into mid-cap because of intramyocardial, and then couldn't put an endoclamp. And so I think it's important for us to respect Elaine and Fred Moore. This has all happened in May, early May, and May 25th, Fred Moore did 5 attempted cases. Thank you very much.
Sure, and you also need to be thanked for your pioneer work in robotic midcap. Okay, thank you.
The ethics committee in Leipzig was very clever in putting a mandatory mid-cap incision. So I think a bailout is always an important in any surgeon's mind. So I think they allowed to do the TCAP with a mid-cap incision as a bailout. So I think it's very important because by the time the mid-cap was already established a little bit, because we did in 1994, April. So everybody adopted quickly in that 1995, 96. And the stabilizer was already formed, and the shunt was started to come in. So I think mid-cap formed a platform for this robotic interest.
Johannes, you have been there from the very start. You have been doing all the techniques. So what would be your advice for new people stepping in? What are the 2 pitfalls or the 2 best advice that you would give to new starters that want to do this kind of procedure?
The 2 advices to give are to go a strict stepwise approach. This is not a procedure that you jump into. That's not see one, do one, teach one, of course. Is a lot of simulation in low fidelity models, repetition, specifically when it comes to the anastomosis, okay? And stepwise approach, don't introduce new technologies, several new technologies at the same time.
So we should also remind everybody that currently there's only the arrested version of the TCAP is doable if you want to stay completely not kind of being very experimental, put it that way. You all know that Gianluca has a good way around missing stabilizer. We also have rumors that stabilizer might come from different robotic platforms, hopefully. Yeah. But as of today, I think the TCAP, I think you're counting the number of institutions doing it. I think we are less than 20 institutions worldwide. What is the exact number?
20 is the current number of institutes doing the TCAP procedure.
So hopefully next year ISMICS, this is a kind of a moving number. We will get much better. And talking about challenging situations for robotic procedures, when the US for the mitral is considered routine, TCAP is still a little bit, let's say, behind, but we'll see what's going to happen there. In Europe, we have different situations. So Stepan is going to give the next presentation on how we in Europe experience the, not existing support for robotic cardiac surgery in the past, which is going to change very rapidly, and also we will most likely then help with moving the numbers for the TCAPs. Stepan, please.
Dear Mr. Chairman, ladies and gentlemen, good morning. First, I would like to thank the Society for the opportunity to give this talk, and for me it's really a privilege and honor to share the podium with such a giants like Johannes Bonatti or Dr. Srivastava. I would like to talk about the robotic cardiac surgery in Europe. This is my disclosure. This is my experience with robotics. It splits into 2 areas between 2 systems and 2 hospitals. And today I'm not only following the steps on the podium, following Johannes, but also in the beginning of my experience, Johannes was my first mentor and proctor, and we did a lot of cases back in 2007 with the standard system. The current era started in 2016, and in the meantime, over a period of 8 years, I had a privilege to train 25 teams across Europe, and those teams that finished the training before end of 24, they performed almost 3,000 cases. Going back to the history, European cardiac surgeons were really the first worldwide to use the robotic technique, as was already mentioned. Professor Carpentier, Didier Lumet, Fred Moore, the first series of mitral valves, beating heart, TCAP, hybrid procedures. So the pioneering work happened here in Europe. There is quite limited evidence about the annual numbers of robotic cases performed in Europe. It's mapped by these two papers by Matteo Pettinari and our group. Matteo showed that between 98 and 2010-12 was not very much growth of the procedures, limited number of centers, but everything started with the first generation of the system, the first system which was really suitable for robotic cardiac surgery. Then we managed to introduce a structure training in robotic surgery in Europe. There was a renewed interest. It led to EACTS robotic task force establishment in 2019, and it really gave us a power to change things, to move things forward. We felt very excited. Everything looks bright, but sorry. I missed one slide. Oh, sorry. Yeah. So we managed to double number of centers between 2016 and 19, and with a quite common mix of cases, half revascularization, half intracardiac, and others. And this is what I was talking before. Everything looked bright, and in May 21, all centers received this letter announcing discontinuation of the support from the industry, which was based on the newly introduced MDR. The MDR was a medical device regulation newly introduced in Europe in May 21, and it is a very complicated document, and it basically stratifies the procedures in 3 classes or 4 classes, 1, 2A, 2B, and class 3. And the class 3 is the most complex one regarding the certification. So based on this change of the medical law or regulation in Europe, the industry withdrew the support, and the MDR created a new regulatory environment in Europe. The robotic cases are split between the class 2B regulation and class 3 regulation, class 2B for revascularization. What does it mean? Class 2B, it's because it's classified as a thoracic procedure. It's only for IMA takedown, is perfectly on-label procedure, and it's industry and ECTS supported procedure with a supported training pathway. You can go for an EACTS revascularization course. You can join the industry supported training, case observations, and proctored cases. In intracardiac robotics in Europe, the situation is different. It's classified as a class 3 procedure, and at the moment, no robotic device with MDR class 3 classification certification is available in Europe, except for a historical Da Vinci SI system. So most of the procedures are off-label, and currently there is no official training pathway available for intracardiac procedure. But despite that, some centers continue to perform intracardiac robotics in Europe. There are different ways how to do it, different derogations from the MDR regulation. This is what works in my country. We are the only country in the European Union which has got a specific national medical law which allows to use the devices off-label with the informed consent of patient in cases where there is enough medical evidence that it's profitable for the patient. So with this regulatory background in my country, we were able to gradually increase the number of mitral valve repairs. There's no limitation. There are some other centers in Europe performing intracardiac robotics. All of them under different derogations. Some of them are using the SI system, some are using national exception, institutional approval, or scientific protocol. The number of intracardiac cases doubled between 24 and 25. It's mainly thanks to Jörg and his center. So in the past 5 years, we sometimes felt like Magnificent Seven fighting against almost everyone. But we managed to gradually increase the number of centers. And in 25, the support from the industry started again. And you can see the effect here on the number of centers, and especially in this part of the European map, which is Germany. Germany is now growing very fast, starting a lot of new programs, and some are coming. It was not only struggle and fight. We also learned some lessons from the past 5 years. We learned that there is a very important role of the scientific societies. The scientific societies has to play a very important role in introducing new technologies, and by working with the industry and by setting up the standardized curricula and training pathways and learning pathways. This has already happened in the US. STS this year published the expert consensus statement. The same is happening in Europe. This will be published very soon. So if I go back to the original question, how to establish a robotic program in Europe under current circumstances. First, we have to admit that today establishing a robotic revascularization program and a robotic intracardiac program are fundamentally different projects. In revascularization, you just can join the existing industry and CTS training pathway. In case you don't have access to the robot yet, you can start or master your open mid-cap program, your OPCAP program, which is unnecessary steps before starting the robotic revascularization. In the intracardiac, it's a little bit more difficult. At the moment, we don't have a structured training pathway. So you should start and master your minimally invasive or transaxillary program. You should try to modify your valve procedures to future steps into robotics, like modifying the cross-clamp technique, repair technique, using open ring instead of closed. You should start building your team. Start a discussion with your hospital administration, and the industry partner. And of course, get ready for the future, because the future can be closer than it looks now. So let me conclude. I believe that the challenge in Europe is no longer technical. We have the robot, we have the procedures, we have the evidence, we have the surgeons, but the challenge is regulatory. Coronary and intracardiac programs are different and currently face different regulatory realities. Successful implementation requires structured training, team development, and regulatory planning. The next challenge for us robotic surgeons is not proving the value of robotic surgery. It has been already proven. But we have to ensure that the patient can access it and access it safely. And despite all these facts, we can see that the robotic cardiac surgery is expanding rapidly across Europe. And we must not forget that robotic surgery or robotic cardiac surgery is not a procedure. It's a platform for all of cardiac surgery, and even in Europe. Thank you very much.
Can I ask a question?
Yeah, sure. Comment from the panelists.
Do you think that it should also, we have seen also they use it for heart transplants and lung, do you think they should expand to that? Does it have a benefit for that?
Sorry?
Does it have a benefit to do heart transplantation with?
Yeah. You know, the platform from the technical point of view can be used for almost any procedure. The heart transplant has been done, lung transplant has been done. It's more a question for the transplant surgeon if they see any advantages. Probably in a young patients, transplanting the heart with preserving the sternum can offer them a better chance for second transplantation or other things. But it's at the moment limited experience worldwide with these procedures.
Stefan, thank you. First of all, great presentation. Secondly, thank you for your help with helping us in Liverpool with our programme. Have we got any update yet on MDR when we're expecting the approval for DV5 to be given for intracardiac in Europe?
It's very thanks Paul, thanks for the comment. It's a very common question nowadays, and it's always the answer is hopefully coming, but nobody knows or can't say when.
Let me put it that way. I don't know nothing, and they also not want to tell me. But I'm also chair of Techno College for EX, just come to Barcelona, and currently I plan to show live case with Da Vinci 5, and this is only going to be possible if there's MDR. And let's put it that way, Intuitive is not holding me back. So maybe they know more than we do, and I think by October it should be solved. Whether or not it will include aortics or whatever, and what is with TCAP and these kind of nuances, I guess we will have to wait and see how this plays out. But the minute we have MDR for mitral, and we can do a Lima takedown, this I think is going to get us started. And all these nuances, what is about TCAP, where's the stabilizer, aortic valves, and all these other things, what is about the next industry partner that might come into play, I know they are getting ready, we will see. But the first big step is that we can do on-label mitral repair.
So, yeah, definitely.
Stefan, congratulations for your effort in the Czech Republic and in Europe. It looks like you're classification 1 in Czech Republic. It's that is, if no instruments are available, that looks more like a compassionate, some sort of a modified compassionate pathway. Can that be copied in the other countries in Europe, number one? Number two, for both of you, how far or how near you are with the MDR approval for robotics?
Many, to shorten this a little bit, it's very easy. It's only a couple of weeks until I expect MDR, because this is what we plan for EX. And after October, when EX is going to happen, I think the problem is not going to be MDR. The problem is going to be how do we cope with the interest. So are we ready with training resources? I mean, Stefan has trained 25 teams, which is a huge achievement over how many years, Stefan?
8 years.
8 years. And I think you get email every day about people reaching out to train. So I think that the bottleneck is not going to be MDR. It was the bottleneck. It's going to go away this year. But then the question is, industry partners and also us, right, as the more experienced robotic surgeons, are we ready and can we cope the demand? And there will be a kind of a triage system, if you would like to say so, because we need to first train those centers that we think are going to be able to train the next, to have a kind of a multiplying effect.
Yeah, exactly. The MDR regulation will be, or the MDR problem will be passed in a few weeks, and now we will be facing new problems, but it's more enjoyable than before.
Yeah, Thomas Olbetz from Nuremberg, Germany. Congratulations, Stepan. Very nice talk. Jörg, you and Jörg, I think there's another problem. Another problem is the administration. So we have to persuade our hospitals that Da Vinci and the robotic surgery or cardiac surgery is the way to go. Because at the moment, if I go to the hospital and I experience when I was appointed a new position, you ask them, I would like to start with robotics. Say, why? Why do you need it? You have your endoscope, you do the same job, and it's like much easier. It's much less cost effective. So that's a problem, I think.
Yeah, definitely, it's a multi-level problem. The reimbursement problem. The situation is different in different countries in Europe. In some countries, it's reimbursed, and some countries even the general robotic procedures aren't reimbursed.
Thank you.
So, Nirav, I think we need to move on, huh?
Yes. So next talk, thank you, Stepan. Next talk will be given by Dr. Srivastava. He's going to talk about David versus Goliath, what makes us unique.
Morning, and thank you guys for giving me the topic. I didn't choose this topic, by the way. And we are David, I guess, based on what has been asked of me, and you guys can guess who is the Goliath. My disclosure, I still have to say I'm a cardiac surgeon still because there are challenges in the minds. So where are we now? First of all, I want to really declare, if you look at on the right side, the Da Vinci, I guess that's the Goliath, based on what the organizers wanted. 28 years in existence, almost 11,000 plus systems are out there. As SSI, we've been there for 3 years, and 210 plus systems are there. And so really, the robotic surgery exists. I think there are a lot of pioneers who are sitting in this room, and absolutely grateful to them. Introduced surgical over 20 plus years, and I think the way we want to really see, we are not going to set out to slay the giant, as I guess the David and Goliath story goes, but set out to walk along one. I think it's high time that the industries start to look at each other as doctors do, as colleagues. And ultimately, we are all trying to benefit the patients in the end. So if we keep that, and so that the whole kind of negative side goes away, and we can hopefully jointly do things together. Technology, if expensive, is not going to help masses, and we have seen that over the years. The penetration of the robotic system has been very uneven. Almost 7 billion people today globally do not have easy access. And the most important reason has been the cost. And so despite that, I think it is high time that we really revive. We have seen the benefits of robotics in cardiac surgery. I think hysterectomy is good for the surgeon, but not for the patient. So it's really, we need to find a way to absolutely revive, because it's a wonderful way of doing most complex operations actually with the robotic system. These are the facts here. Globally, it's only 1% of the procedures today are done robotically, which is dismal. Systems, only 5% are available to rest of the world other than the developed economies. And of course, the finances are projected to be very high. Results have been really good. People who have been doing these cases and in experience hands, I think the results are wonderful. Bunch of guys are sitting here who are pioneers and have shown actually it is all absolutely doable. And so the whole goal for us was really to create a system that will be cost effective. And the question again that was raised here in Europe, in terms of the access, I think it is very important. If it is expensive, again, as it did not penetrate Europe or many other countries around the world, same problem will exist. So I think it's very important the technology must be cost effective for patients to access it. Why I decided to get into it. And I had a 22-year-old patient with ASD who could not afford and never had the surgery, even though because the hospital wanted to charge. This is when I moved back to India after having done about roughly 1,400 cases in US and more than, I think, 750 or TCAPs. But that's really what prompted me that we must do something, that we can create a system with the clinical experience and also make the technology that will be different, more advanced, and more specialties, including cardiac. So this is what we actually achieved. And the whole idea was to make it accessible. So since then, we have now done over 11,000 cases in 200 plus hospitals, 600 plus cardiac cases, 175 telesurgeries, and we are the only ones who have done robotic cardiac telesurgeries, and wonderful results actually in relation to overall. There is a cardiac experience particularly. Again, majority of the surgeons start out with the Lima or Bima takedown and then do thoracotomies. And then again, the whole list is there. We have now done 20 TCAPs. And thanks to guys like Dr. Lalit Malik, who is sitting here, I know he will be talking, and also Dr. Nitin Rajput. So some of these, and it's very early experience, by the way, a little over 2 years. And it is evolving. And now, essentially, everything has been done, including aortic valve recently. Our system is different. The idea was to make it different and not copy. And it is a modular design, open-face console, large 32-inch 4K 3D monitor. And there's a monitor on the right side also, which is 2D. One of my biggest challenges used to be looking through this tiny tile pros. And if you put an angiogram or any other CT or MRI, you can't really tell anything, including EKG. Every time I had to ask how the ST is doing. So we have created whereby you can put all these images on the right side separately and also convert these into 3D model. So we have a software program that, and immediately you can slice through, rotate, and you have the anatomy in front of you. There is a 3D on the vision card for everybody. I think I really wanted it because it is avoids accidents, and I think it is shortening the learning curve for the tableside team, and it's great for teaching and training because everybody sees the same thing. Modular design allows you to use 3, 4, or up to 5 arms. IMA takedowns, you don't need 4 arms. ASDs, 3 arms are enough. And media shrunk. Quite a few procedures actually can be done with 3 arms, but we have up to 5 arms because we are developing enabling technology, particularly automated coronary connector, that we can use the 5th arm to deploy that. All different cardiac specific instrumentation we have, including a stabilizer. And also we are developing this connector, we are calling it NADI. And so literally the full spectrum is there for full spectrum robotic cardiac surgery. We also now have developed 5mm instruments that will be useful, particularly in children or even for IMA takedown and other things. And especially if you have to use the stabilizer, you can bring the other regular 4th arm. We have developed a chair and literally have redefined work from home. I had operated back in November of last year from my living room and Dr. Lalit Malik's place in Jaipur. I did a cardiac case actually. And in fact, now we are using this thing routinely whereby we don't have to tie up the operating room. You can place this wherever and you can do telesurgery from wherever. Teleproctoring, I think, is very important. Is one of the challenges that is very difficult to find because only a small number of people are there, first of all. And they can be flying here and there. So teleproctoring is really wonderful today, wearing the VR glasses. I have guided surgeons from my office having lunch, so don't have to travel. And I think if you look at the next step is combination of teleproctoring and telesurgery. So when there is a challenge, you can take over and help the person out at the other end. And we have found it to be safe so far. There have been no conversion in all these 175 cases. And also recognizing the distances, the latest one I did in May from Georgetown in Guyana to India, 20,000 kilometers away. We did a case also, I think Sam was there, from Strasbourg to India. And essentially, we have demonstrated that it is absolutely doable with totally acceptable latency. And I think the latency will continue to get reduced as we are moving forward. We are also starting, I think there was a point made about teaching and training. So as of actually 19th of this month, we are starting a 5-day, very concentrated training program, whereby not only we'll teach them about technology, but every little step, how to do things and how to troubleshoot, how to get out of problems, etc. And all the giants are involved in this effort. I think this will be a great thing for both the surgeons as well as the staff to learn very systematically, because otherwise it's kind of on-the-job training. So David has survived. And the bigger picture really is how to serve humanity. And the idea is really to democratize access through making it affordable while not compromising the quality. So here is what David is doing next. Let me see, next slide. Oh, there we go. So I think the whole idea and some of these sutures that you saw last, trying to find a way to create, again, interrupted anastomosis like the U-clips used to be. So all kinds of things are going with a tremendous focus, of course, on cardiac and use of teleproctoring and telesurgery. So what makes us different and unique? I think hopefully I've communicated that. Thank you very much.
Thanks a lot for sharing the vision. Questions for Sudhir?
Yeah. Thank you very much, Dr. Srivastava. It is really an honor to listen to you here today. Before your presentation, when I saw your title, I thought you are going to talk about that between conventional cardiac surgery and robotic surgery, but you compare other things. But my question is different perspective. The many surgeons interest in minimal invasive surgery under direct vision or thoracoscopic full endoscopic surgery. My question is that, do you suggest to surgeons interest in and thoracoscopic and under direct vision should switch to robotic surgery, all of them?
Yeah, I think so. And I think the wonderful thing about the thoracoscopy part is now we have 3D endoscopes available compared to in the old days, the 2D. And I think that will be tremendously helpful in getting started. And then, of course, I think one can transition on to the robotic, whereby you have all the technology benefits that are there with the technology attributes in terms of literally, articulation. I think all that is very important, but I think somebody wants to start with endoscopy part approach. I think it's perfectly fine. Yes.
Sudhir.
Yeah.
Great cinematic effect, and I don't know who directed this fantastic movie. And I have one single question. I worn the 3D glasses in my career, and it always gives a headache, number one. Two, how different is this? Because it looks like you have a 3D glass. It's almost like the old head-mounted 3D glass from NASA. And it is not an immersion technology where you're really immersed, not distracted by anything else, like your competing technology. Can you tell me the difference, and will it make some argument in favor of immersion technology, or are you going to the immersion technology?
I don't think, and we've heard this long time, I think and Dr. Fred Moll actually is involved with us now, so I used to ask him this question. But I think during those days when they developed what came out as Da Vinci with immersive vision, it was, the SRI, Stanford Research Institute, it kind of got passed on to things. I think those days 3D monitors were not there. Things are very different today. I think if you look at a lot of new companies, they're all going for open-faced consoles, much more comfortable. You get to sit straight, you have complete awareness, larger magnification. So all of those, and I think as far as the headache part is concerned, we have never experienced, first of all, you are wearing these passive glasses. And even with this chair, which has got augmented reality glasses, beautiful 4K vision, no issue at all in terms of having either a strain on the eyes or headaches.
So the answer is you'll stick to your open face 3D glasses and out, not an immersed.
Yeah. Absolutely,
In many other fields of visual, they go to immersion, not just cardiac surgery, but everything else. So.
Yeah, if you look at the whole laparoscopy world, is all open-faced, much larger than robotics. Yeah.
Thank you, Sudhir.
Okay, thank you.